Dear members of White Army, welcome you all for the special session of Medicine Mentor. In today's session, Dr. Rajashekhar who is a mentor of White Army and also a consultant physician, going to discuss about one of the most important aspect of medicine, that is sepsis and septic shock. It's equally important for undergraduates, for the university examination, and for again for NEET entrance exam point of view, and very important for postgraduates. It's a invariably long question for all the postgraduates, maybe surgery, medicine, pediatrics, all the branches. And for budding consultants, it's a must know. So thank you for choosing such a valuable topic for us, Dr. Rajashekhar. Welcome to you, and let's start the session.
Okay, thank you. Yeah, as Dr. Kishan rightly said, the importance of this particular topic, that is sepsis and septic shock, is both for an undergraduate and especially for the postgraduates and the consultants, very important topic. And as much as the importance it has got, a similar amount of controversies also exist in this particular topic. Because we know that there is a particular society which works to provide the guidelines regularly, that is called as the Surviving Sepsis Campaign Guidelines, which recently came, I think, last year, 2022 update. Actually, a lot of the emergency physicians and the intensivists and the anesthetists who practice the emergency medicine are raising a lot of issues regarding the Surviving Sepsis Campaign Guidelines, because which has been very targeted society as far as the guidelines is concerned. If you take other society guidelines, as far as hypertension is concerned, the coronary artery disease is concerned, the cardiovascular, the neuro, all the guidelines which has been provided with the respective societies is entirely used in the practice. But this particular guidelines is receiving a lot of criticizations rather than the practice oriented thing. Although in India it is not a big issue, because we neither follow any guidelines nor listen to anybody. We tend to practice our own issues, and the majority of the part of practicing world, the insurance is not the big issue. So these guidelines does not tend to affect us much. But the basic knowledge of the physiology, the basic knowledge of the hemodynamics and the pharmacology and the pathology is a very, very important for you to practice this sepsis and septic shock and to prevent the death of the patient. None of the guidelines are going to come to save the patient. It is your own knowledge during the time of management is going to save the patient. So it is not a difficult topic. It's a very easy topic. But the thing is, you should know the basics very, very right. And initial days of your practice, you should commit mistakes. Then only you will understand what you are doing wrong. So sepsis, again, it is not like a broad infectious diseases anyway. The sepsis is a one entity where the time matters. Like the myocardial infarction and stroke, the time is the muscle, the time is the brain tissue. Again, in the sepsis, the time matters because it is one of the very important, the time-dependent issue in which the time is very, very important. The early management prevents the death of the patient. And the early recognition and the rapid institution of resuscitative measures are very, very critical. And recognizing sepsis can be challenging. It can be very challenging for some people. And even after recognizing, the management continues to evolve because, as I told you, that there are a lot of controversies and a lot of changeover guidelines and a lot of individualized protocols in this particular thing. So before going into sepsis, the sepsis is like continuum of an infection. So any infection, if it increases in the severity, may go into sepsis. So that is what is the basic understanding of this terminology called sepsis. Sepsis, the basic meaning is the rottenness. The rotting of the tissues is called as sepsis. So we should know how to differentiate between an uncomplicated infection and how it is progressing into a sepsis. This is the major important thing. We, in our day-to-day practice, we tend to see a lot of infections. We see the simple upper respiratory tract infections, simple pneumonias, complicated pneumonias, uncomplicated UTIs, the intra-abdominal infections, the soft tissue infection. Many of the infection, 50% of our practice is infectious diseases. So we should know how to differentiate between an uncomplicated infection and a sepsis, because the uncomplicated infection needs just an antibiotic treatment or an anti-infective treatment, whereas sepsis is a multimodality treatment where it is an emergency issue and the patient can rapidly become sick and may ultimately die, as similar to you might have seen in the cases like acute myocardial infarction. You might have seen a patient of an acute myocardial infarction suddenly going into a cardiogenic shock or an arrhythmia collapsing in front of you within a matter of an hour. So similar kind of dramatic events can occur in this particular event called septic shock. Especially the terminal events, they are very dramatic. The patient looks absolutely fine in front of you. Suddenly patient collapses. This is not like the shock of an hypovolemic shock or the neurogenic shock. The patient can suddenly collapse in front of you. So that's why it is very important to understand when the patient is going from an uncomplicated infection towards the sepsis, to prevent the patient going into septic shock, and if the patient is in septic shock, to prevent the death. So we should know some terminologies, basic terminologies here. The bacteria, we know that infection can progress into bacteremia. The bacteremia literally means the bacterial presence in the blood. It is not equivalent to sepsis, whereas it is just a presence of bacteria in the blood. Whereas septicemia is also called as blood poisoning. Layman language, it can be used as a blood poisoning. So it literally means the rottenness of the blood, and it is composed of this Greek word sepsis, which is mean like a putrid or rottenness. So this was introduced by a German pathologist, that is Rudolf Virchow, and the sepsis is a state of this rottenness. So we should know what is the difference between bacteremia and septicemia, and potential question for the undergraduates. Very important to know the difference of this particular entity. Bacteremia is just a presence of a bacteria in the blood, whereas septicemia is a syndrome. Septicemia is a syndrome where, along with the presence of bacteria, the body is reacting to that bacteria in a very unrequired way. So let me provide a case to you here. This is a common entity nowadays in the OPD, especially in the COVID period. The 32-year-old female who is an engineering student presented with a complaint of 5 days fever, high grade, associated chills, throat pain, and for which she consulted 2 doctors in the last 5 days with no relief. And to present to us, she had a pulse rate of 112, the blood pressure of 90/60, the respiratory rate is 22, saturation was 96, the temperature was 101 degree Fahrenheit. The bilateral tonsils were enlarged with pus pointings present. So the patient had an acute tonsillitis. So in this particular kinds of scenarios, you should know whether the patients have an uncomplicated infection or she is going into sepsis. So what is sepsis? You should know. So is it sepsis or it is just an uncomplicated infection? Let's learn, differentiate between these two things. So if you take the definitions, the sepsis was initially described as a putrefaction or the decaying of an organic matter. And the germ theory by the Lewis Pasteur and the colleagues came into the existence. The sepsis, where the infectious materials came into the existence, who discovered the microorganisms, which are the culprits. Then in the William Osler in the early 1900s, so he discovered that it is not the bacteria actually which is creating the issue here. It is the reaction to that infection by the body which is creating the issue. So again, the focus which shifted from the pathogenic bacteria to the body or to the host immune response. So to all these basic background in the early 1990s, the terminology called CIRS, came into existence, that is a systemic inflammatory response syndrome. So this SIRS is an infection induced. So it is a reaction of the host toward the infecting microorganism. That is what was called as the SIRS, that is the sepsis 1, which has been published in the 1991 and 1992. And from that, there are a lot of changes which occurred over a period of time. There came in sepsis 2 in case of 2001, and there came sepsis 3 in 2016. In 2016, when I was first year PG, this sepsis 3 came into existence, so which defined the terminology of life-threatening organ dysfunction, which is resulting from an infection. They removed the terminology called SIRS. So earlier in 1992, the sepsis was defined as a systemic inflammatory response syndrome due to a suspected infection with 2 or more of the following criteria. So these criteria were called as SIRS criteria. So the patient who is suspected to have any infection, if he meets any of these 2 of the 4 criteria, used to be considered in sepsis. The criteria were 4 criteria in which the temperature, heart rate, the respiratory rate, and the white blood cell count was taken into account. Temperature of below 36 or above 38, the heart rate above 90, the respiratory rate more than 20, the WBC of less than 4,000 or more than 12,000 or more than 10% of band to the left shift. So any 2 of these 4 criteria, if the patient possesses in the background of a suspected infection, the patient was used to consider to have a sepsis. So let's go back to the case. So here there is a suspected infection here. Yes, her tonsils are enlarged, the pus pointings, we have got a focus. And if you take the SIRS criteria, yes, pulse rate is high, the BP is quite low, tachypnea is there, temperature is high. In fact, she meets 3 criteria. So if you follow this particular early guidelines of SIRS, the patient used to meet the sepsis criteria. So this was the problem with the earlier criteria of SIRS. Even the tonsillitis used to qualify for the sepsis. So similarly, it used to happen with dengue, it used to happen with simple upper respiratory tract infection, uncomplicated pneumonias. See, this SIRS is a systemic inflammatory response syndrome. This is a very non-specific syndrome. Here it responds to like this, occurs in every infection. That's why there came a reviewable definition nowadays. So in later 2001, that is sepsis 2, included 2 other terminologies, what it is called as severe sepsis and the septic shock. The severe sepsis was a progress of sepsis, that is an infection plus SIRS. If he progressed into any organ dysfunction or tissue hypoperfusion or hypotension, if he has any one of these 3, along with the infection plus SIRS, either organ dysfunction or a tissue hypoperfusion or a hypotension, then he used to be called as severe sepsis. And if this organ dysfunction persists despite the adequate volume resuscitation, he used to consider be in septic shock. But what happened in the recent guidelines was they removed this terminology called severe sepsis. The severe sepsis terminology is not used nowadays. There are only 2 terminologies. One is sepsis, another one is septic shock. So nowadays you should know there are 2 terminologies, the sepsis and septic shock. There is no terminology called severe sepsis. Don't use the terminology called severe sepsis. So what changed the definition is sepsis, they defined it as a life-threatening condition which is caused by a dysregulated host response to an infection resulting in organ dysfunction. So you should know this definition. In this definition, there are 2 important terminologies. One is there is a dysregulated host response to an infection which results in organ dysfunction. So there has to be an infection and there has to be an organ dysfunction to the patient to qualify for the sepsis. And if this organ dysfunction persists despite the fluids, then it used to call a septic shock. Septic shock, as far as definition is concerned, it is a circulatory, cellular, and metabolic abnormalities in the patients who has sepsis, which presents as a fluid refractory hypotension requiring a vasotherapy associated with the tissue hypoperfusion. So if the patient who is in sepsis, you are given adequate amount of IV fluids initially, Yet his tissue hypoperfusion is not solved. He now needs the vasopressor therapy for the maintenance of the tissue perfusion. Then he is labeled as in septic shock. Septic shock is a diagnosis which comes after the starting treatment. Please remember this. It is not like you decide septic shock, then you start vasopressor therapy. Only when you start vasopressor therapy in the patient of sepsis, you label them as in septic shock. So what do you understand by this definition of sepsis? So to label a patient to be in sepsis, there has to be an organ dysfunction in the background of infection. Now the question comes, how will you decide the patient has an organ dysfunction or not? So earlier we had a SIRS criteria. So this SIRS criteria used to define the amount of inflammation. So in the recent definitions, the game or the focus shifted from inflammation to the organ dysfunction. Initially, the earlier guideline used to focus on the inflammation, but nowadays they are more concentrated on the organ dysfunction. And this is rightly done because, as I told you, a SIRS criteria, a tonsillitis would have qualified for the sepsis. So in the earlier, they used to measure the level of inflammation by the criteria called SIRS. Nowadays, you have to prove the patient is in organ dysfunction to qualify for the sepsis. So to define organ function, they provided a criteria called qSOFA, that is a sequential organ assessment score. So the organ dysfunction in the new criteria of sepsis is assessed using the qSOFA score. It is called as the sequential organ failure assessment score. The qSOFA score is a very tedious score to calculate in the emergency room, but a very frequently followed scoring system in the ICU. There is a difference between an ICU and an emergency room. When the patient comes to you suddenly to the emergency room, you don't have qSOFA score until and unless patient has visited some other hospital, carries some reports. Whereas if you see the patient for the first time, the qSOFA score is very, very difficult to get because it contains all these information. It basically assesses the following systems. It includes the respiration, in which they measure the PF ratio, and it assesses the coagulation, in which they measure the platelet. The liver is measured as the level of bilirubinemia. The cardiovascular status is measured by the mean arterial pressure. The central nervous system is gauged by the GCS scale, and the renal parameters are by two criteria, that is the creatinine and urine output. So please remember, respiratory rate is not included in this. The tachycardia is not included in this. So very, very important in sequential organ failure assessment score. So this can be the entrance question. You should know what are the systems involved, what are the factors involved in it. Although you may not remember these values, you need not remember these values. You should remember what are the points involved in this particular qSOFA score. So if you see this qSOFA score, you need to have a lot of laboratory values available to you at the time of diagnosis. Then only you can assess the qSOFA score. It is not like qSOFA score was not there in the earlier time. The qSOFA score was there. We used to use it for the assessment of the patient of any organ dysfunction, be it a pancreatitis, be it multi-organ dysfunction of any cause, be it the cardiogenic shock. We used to measure this qSOFA score, and it is very useful for the sequential assessment. Like if you have calculated the qSOFA score now, what is the qSOFA score by next 6 hours? What is the change in qSOFA by 24 hours? So if there is an improvement in the qSOFA score, if there is a worsening in the qSOFA score, it used to match with the patient's mortality. So they included this qSOFA score in this sepsis. So qSOFA score is a must and the inherent involvement in the sepsis definition nowadays. So when will you define when the patient has organ dysfunction? The patient is considered to have an organ dysfunction and there is an acute change in the qSOFA score of more than or equal to 2 consequent of an infection. So to call a patient be in sepsis, he need to have an infection plus an organ dysfunction. An organ dysfunction is measured by a qSOFA score. How much change? The patient need to have a change of more than 2 or equal to 2 score. So this can be very easily done if the patient develops sepsis inside the hospital. For example, if you have admitted the patient for some other issue, like patient is admitted for the acute decompensated heart failure, patient develops pneumonia, you have an earlier SOFA score, now you calculate SOFA score after 48 hours. If there is an acute change in the SOFA score in the background of a new infection, then you can straight away label the patient as in sepsis. But it becomes very difficult when you have a first SOFA reading. You need to wait for the acute change in the SOFA for the next 8 hours. By the time patient might have progressed from sepsis to the septic shock. So whenever you don't have a baseline score, the baseline SOFA is considered as 0 in absence of any previous organ dysfunction. If the patient of healthy well-being does not have any end organ damage in the patient does not have any nephropathy, the myopathy, cardiopathy, it does not exist, then he comes with the new symptoms, young patient, then his baseline can be considered as 0. But it is very difficult for an old age patient to consider baseline SOFA as 0. And how much mortality it predicts, a SOFA score, an acute change in SOFA score tells that the overall mortality rate has increased by 10%. So if it is 2 now, if you come again in the ICU, you calculate the SOFA score, now it is 4, then the dying chance has increased by 10%, now it is 20%. So this is how the meaningful the SOFA score is. And this SOFA score can be calculated prospectively and retrospectively, and it can be calculated either manually or by an automated system. You have got a calculator online available, you need to just put the values, then you will get the score. So since it is a very cumbersome process to have all the laboratory reports, then they created a very short formula for this that is called as qSOFA, that is qSOFA. So in this, they considered 3 very important issues of the organ dysfunction. One is the altered mental status, another one is the systolic blood pressure, and the respiratory rate of more than 22. So please remember, the respiratory rate is present in qSOFA, whereas respiratory rate is not present in the original SOFA. So these can be the potential entrance questions. These have been already asked in the NEET SS, but these might come in the undergraduate NEET also. So you should know what is a qSOFA at least by heart. Whereas original SOFA, you may not remember, you just remember the contents involved in this. So qSOFA consider 3 abnormalities. One is the GCS, that is altered mental status, the systolic blood pressure of less than 100, and the respiratory rate of more than 22. So if the patient qualifies, if the patient has 2 out of these 3 criteria, then patient is considered to have the sepsis. Then you can go ahead, try to manage the patient as sepsis. Then you can have a blood laboratory readings. Then you can calculate the original SOFA score. Then you go on updating the SOFA, whether it is improving or it is deteriorating, depending on the patient condition. So here I will give you an example here. 3 months back, we had a patient of burns in our surgery ward. The patient was admitted with a 20% of burns, who was an 80-year-old age patient who was diabetic with an incipient diabetic nephropathy. So patient admitted with the burns. So patient was there with us from day 1 to day 9. So what happened on the day 7 is I had a referral for the desired diabetes management. Then I went to see the patient. The patient was absolutely fine. Then just I told the patient that you might get discharged today, but his discharge got delayed by 4 to 5 days from that 9th day. That's because the family members wanted the patient to keep in the hospital because they don't wanted to take care in the home because the wound was, the dressing used to be done. So they told to keep the patient in the hospital only. In spite of telling them the patient might have a hospital-acquired infection if they stay for long. Then, unfortunately, the patient might have developed an hospital-acquired infection. Suddenly, on the 13th day of admission at 10 o'clock, I received a call from the duty doctor telling that surgeon has told you to see the patient of our burns. His GCS is going down. He's not responding to the commands. He's not taking orally. and he is having a respiratory rate of 24, whereas his X-ray is normal, and his urine output has gone down. He has not passed urine from last 5 hours. Although they did a blood test done, the counts were normal, everything was normal. The patient GCS was low, urine output was low, and respiratory rate was very high. So these are the things which tends you to make the diagnosis of sepsis very early. Then we initiated a sepsis protocol in this particular patient. Then we drew the blood cultures again. We sent for the cultures. We administered the antibiotics, and we managed the patient as sepsis. Then patient went into septic shock. Patient got intubated. Patient remained in mechanical ventilation. Then patient had VAP, that is ventilator-associated pneumonia. The patient ultimately had to stay with us for a long 1.5 months to completely get out of the ventilator and to get discharged. So the definitions, you should be able to know how to use these definitions in the practical field. So what is septic shock? Septic shock, we know that there is a patient of sepsis who is having an organ dysfunction. Now in this patient, we resuscitate. After resuscitation, if this tissue hypoperfusion gets solved, then he is not in septic shock. You may just need to continue the patient as you're managing. But if the patient, in spite of giving the fluids, his tissue hypoperfusion is not getting solved, and to maintain this tissue perfusion, you need a vasopressor therapy, then it is considered that patient is in septic shock. So the earlier definitions of septic shock were very vague. They did not define the blood pressure here. They did not define how to measure the amount of the tissue hypoperfusion, etc. But nowadays, it is being assessed in terms like hypotension, the fluid resuscitation, the lactate levels, and the need for vasopressor. So the fluid resuscitation has to be complete, and there has to be a hypotension. Hypotension is defined in the way of mean arterial pressure, not as a measure of systolic blood pressure here. Please remember this. And lactate levels and the need for vasopressor therapy. So when I take a class on approach to shock next days, I will explain you the importance of blood pressure in these patients. So in septic shock, the patient has to have a persistent hypotension despite of the adequate fluid therapy. And even after giving adequate fluids, to maintain this mean arterial pressure above 65 mmHg, which is the target, if he needs vasopressor, with in the background of hyperlactemia, that is serum lactate levels more than 2 millimoles, then it is considered as the patient is in septic shock, where the in-hospital mortality exceeds 40%. So this is a very, very high mortality percentage in the patient of septic shock. So again, to give a clear idea when to label the patient is in sepsis and septic shock, if you have a patient who is suspected to have an infection, calculate the qSOFA. If the qSOFA is more than or equal to 2, then assess for the evidence of an organ dysfunction. Then if the SOFA is more than or equal to 2, then yes, he is considered to have a sepsis. If in this sepsis patient, there's a set of management, then we're going to discuss. So the first thing is the fluid resuscitation. So even after the fluid resuscitation, and the patient's mean arterial pressure is low, and he requires vasopressors to maintain this mean arterial pressure, and serum lactate level is more than 2, then he is considered to have or be in septic shock. So this is very important to understand the definitions. Although there are lots and lots of controversies regarding this in the field of an emergency medicine, but for this undergraduate level education and for early postgraduate education, you need to remember this completely. This has to be by heart for you guys. So to understand the pathophysiology, I will not go into very deep pathophysiology of the sepsis and septic shock. You might have studied in the pathology aspect. So we know that there are microorganisms which are responsible for this, be it a bacteria or a fungus or a virus or a parasite, which can be either community acquired or hospital acquired in the host, leading to an infection. And this infection elicits an immune response, that is an innate immune response and also the compensatory response. So this innate immune response produces some changes in the body. So patients starts to have fever, the leukocytosis, the leukopenia, and the compensatory response is respiratory rate increases, sensorium may go a little down, the hypotension may appear in the patient. So if along with this background, if the patient has a dysregulated host response, we know that there is a host which is responding to an infection which is acquired from the outside. So this infection has to be a very limited response. We don't want an overwhelming response. You might have studied in the COVID. So there is an overwhelming immune response to the virus. Similarly, there occurs an overwhelming immune response. So there occurs a massive imbalance between the pro and the anti-inflammatory response to an infection. So in the early period of an infection, there is a very high pro-inflammatory response with a very low anti-inflammatory response, whereas in a very late period of sepsis, there is a very high anti-inflammatory response with a very low pro-inflammatory response. So this, in the background of an compensatory response and an immune response, leads to an organ dysfunction, which ultimately makes the definition of sepsis, that is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So this organ dysfunction manifests in the very important vital organs. That is, it manifests in the respiratory rate by the reduced PF ratio, in the nervous system by the reduced level of consciousness, by the cardiovascular system by the reduced mean arterial pressure, by the liver it is increased bilirubin, by the kidney by increasing the creatinine and reducing the urine output, and by the coagulation by thrombocytopenia and the coagulation abnormalities of increased INR and APTT. So why this occurs? Because there is a cytokine storm, there is a lot of cytokine storming in the bloodstream, ultimately doing a thing called vasoplegia. So you might have heard the terminology called hemiplegia or paraplegia, in which there is a paralysis of one side of the body or paralysis of both the lower limbs respectively. So similarly, there is a vasoplegia, there is a paralysis of the vascular system. Your whole vascular tone gets paralyzed, ultimately causing a vasodilatation. There is a massive or a massive venodilatation occurring in the patients of sepsis due to cytokine storm. So what happens when there is a massive vasodilatation? In the massive vasodilatation, more in the veins and more in the lesser in the arteries, but do occur in the arteries also. So massive venodilatation ultimately reduces the preload, and the arterial vasodilatation reduces the systemic vascular resistance, dropping the diastolic blood pressure. And since the preload is also low, the systolic blood pressure also falls. So this is also called as a distributive kind of shock. Although you have got intravascular volume, which is normal with the normal human body, but the relative hypovolemia exists due to sudden vasodilatation. And if this sepsis progresses, there also occurs other abnormalities like the capillary leakage. You might have heard this terminology in the dengue. So there is a capillary leakage, massive capillary leakage occurring in the patients of sepsis at the capillary beds in the end organs. So all these organs gets flooded with the intravascular contents. So if it occurs in the lung, it may produce a pulmonary edema. It may occur in the liver. It can cause the congestion of the liver. It can cause the increased intrarenal pressure. So all these can occur due to increased capillary pressure. And if again this sepsis progresses, this will lead to a myocardial depression, manifesting as a diastolic dysfunction. So the hearts cannot accumulate more of a blood. And although in the background there is a preload itself is low due to venodilatation, again in the background of that there is a capillary leakage, and again there is a myocardial depression. So there are multimodal mechanisms causing the patient to have a low blood pressure and the tissue hypoperfusion in the patient. So the management is also the multimodal in these patients. So how will you evaluate and manage the patient of suspected sepsis? So the first and foremost is the three things, that is the stabilize the respiration, establish the venous access, and send the initial investigation. How will you stabilize? If the first is the A, B, C, this is the basic. First assess the airway, breathing, and circulation. If the patient is hypoxemic, put the patient on oxygen. If the patient GCS is very low, if the patient aspirated, consider for mechanical ventilation depending on the sickness level, and target the saturation to 90 to 96, and immediately establish the venous access as soon as possible. The initial point of management, the peripheral line, will suffice, but over a period, majority may require a central line, and some case of refractory septic shock patients may also require an arterial line. So this is a very, very important. Better insert a large bore needle, either a 16 or 14 gauge needle in both the limbs. Better to have two cannulas in two limbs. And send immediate investigation in this. Take the brief history and examination. Don't spend too much time on the detailed history, and send the blood culture labs and lactate immediately. And the next very important thing is an administered empirical antibiotics. So this is the first and foremost thing you see when you see a patient of sepsis. See the patient saturation. If it is low, put them on oxygen. If they're very sick, intubate the patient, put them on mechanical ventilation. Ask the sisters or ask the duty doctors to get the venous access ASAP, preferably by the two different persons, and take the brief history by simultaneously maintaining this. And if you have central line, very rapidly insertion capacity, just insert the central line initially, then take the blood cultures, send the labs from the same vascular access. And the very important, after sending the blood culture, is administer the empirical antibiotics, a very, very important thing. Next comes an initial resuscitative therapy. So what you do in this initial resuscitative therapy is you need to achieve the tissue perfusion with a aggressive IV fluid therapy. I will pardon for mentioning the term called aggressive. So don't be aggressive when I say aggressive in my slides. So be a very comprehensive. You need to have a very judicious IV fluid therapy. Whenever any guidelines mention this particular word called aggressive fluid therapy, irrespective of the patient's blood pressure, don't go with the emotion of the guidelines. Don't go with the aggressive IV fluid therapy. Be very judicious. Be very practical. That's why I have taken the previous class of fluid management. It is very important to assess the patient, whether he's in a rescue phase, whether he's in a optimization phase, whether he's in a stabilization phase, whether he's in a de-escalation phase. Sometimes patient can directly present with a pulmonary edema in the background of sepsis. Then if you follow the aggressive fluid therapy, the patient may die within minutes. So this is very, very important. So just remember, you have to achieve the tissue perfusion and administer the empirical antibiotic therapy, then decide the location of the patient admission, whether the patient needs an ICU admission or he's a step up or a step down. You need to decide the admission. And next is the intravenous fluids. After assessing the patient's situation, stabilizing his respiration and administering the antibiotics, the first and foremost thing is the intravenous fluids. So these lines I have taken from the guidelines. See what the guidelines mentions. The intravascular hypovolemia is typical and may be severe in sepsis. They mention it can be up to 3 to 4 liters. And the guidelines mentions that you need to do a rapid and a very large volume infusions of IV fluids, that is 30 ml per kg. This is by the surviving sepsis guidelines. So the 30 ml per kg rapid IV infusions are indicated as initial therapy of sepsis unless the patient is in significant pulmonary edema. The fluid therapy is administered in a well-defined, rapidly infused boluses. So I will give you an example here. If the patient is weighing 60 kg, so 30 ml per kg becomes 1800 liter. That is 1.8 liter, approximately 2 liters. So if you have decided that you are going to give 2 liters in this patient, then this 2 liters is given as a well-defined boluses, which are rapidly infused. Again, these boluses are to be given when the patient is in rescue phase only, as I told in the previous class. This is been not mentioned in the guidelines. So don't give fluid boluses when the patient is in stabilization phase or the optimization phase. So if at all you are giving fluids, give 500 ml, then assess the clinical and hemodynamic response. What you will assess? Assess the fluid status, whether there is an appearance of an edema after giving the 500 ml NS, whether the patient developed crackles, his JVP has risen after and before giving each boluses. If you are well equipped enough, you can also manage the hemodynamic response. You can measure the hemodynamic responses, whether the IVC diameter has increased or the stroke volume has increased or not. So you can, if you have got a CVP, you can measure a CVP, whether it is increased or not. Then this fluid challenges, the guidelines mention that should be repeated or can be repeated until the blood pressure and tissue perfusion are acceptable and the pulmonary edema ensues or the fluid fails to augment the perfusion. There are three criteria till how much point you should give fluids. Either tissue perfusion is acceptable. Now the patient is out of hypoperfusion, or if the patient develops pulmonary edema, you should stop. Or if the patient does not increasing his perfusion even after giving so many fluids. So now you need to stop these fluid challenges. Then you need to go for a next step of therapy. So this is very, very important. Again, this is what the guidelines mentions. They mention the amount of fluid to be given as 30 ml per kg as fluid boluses. But this is what I follow whenever I follow the fluid management in the patient. So any patient who is having an hypotension with the septic shock, so assess the volume status. So how will you assess the volume status? You take the good clinical history. Sometimes it is very obviously evident that the patient is in dehydration. Like if the patient has a severe vomiting, severe diarrhea, patient has a reduced oral intake, patient have a background of ketoacidosis or a hyperglycemic coma, where the dehydration is bound to happen, or if the patient has the very dry mucosa, his axilla is very dry, his tongue is very dry, his eyeballs are sunken, he's shooting his pulse rate into 120, 130, his blood pressure has dropped, with the background of vomiting, severe diarrhea, yes, there is no doubt the patient is in dehydration. And know whether the patient has a previous cardiac dysfunction, whether the patient has a previous cardiomyopathy, patient has some stenotic lesions in the valve, patient of a pulmonary hypertension, very important to assess the fluid status because they already have a pulmonary hypertension. A very little amount of IV fluid can push them into a frank pulmonary edema. Then if you are trained enough, you can have a bedside echocardiography done, although it is very difficult in a critical case setting to assess and everything. You can just see for the RV, you can just see for the LV, you can just assess the stroke volume and look for some pericardial effusions, some pleural effusions, the B lines in the lungs. This happens to be a very useful when you assess the fluid overload. Then, is there any increased risk of harm from the hypervolemia? Like if the patient has pneumonia, they have a very high tendency to go into ARDS with a minimum amount of fluid compared to other infections patient. So you need to be very careful whether the patient can tolerate even a mild amount of hypervolemia or not. As I told in the previous class, the patient is told to have a fluid overload when he has more than 10% of the extra fluids. So in patient of pneumonia, even 3% to 5% of extra fluid can make them go into a frank ARDS, which is a very life-threatening condition. So after assessing the patient, take a good and a very short history. As I told you, the patient may have vomiting, diarrhea, reduced oral intake, diabetic ketoacidosis, overdiuresis, severe hypercalcemia, etc. If they exist, if the patient appears in a frank dehydration, yes, you can consider them giving a very larger amount of fluids, like 2 to 4 liters can be continued, but give the fluids slowly after giving boluses. If the patient is not in absolute shock, give the patient's fluids slowly, follow the hemodynamics. What if the patient is having a contraindication? So if the patient has a systemic congestion already presented to you with the fluid overload, there is severity of lung failure is very high, the cardiac dysfunction exists, the patient is undergoing a dialysis. So now you need not have a very rigorous fluid resuscitation in this patient. Provide a very little, just a maintenance or no crystallized resuscitation can also be considered in these kind of patient, irrespective of a septic shock. What happens in the average patient? You don't know. There is no history of any dehydration, or patient does not appear to be dehydrated. You don't know the cardiac history. Patient is not fluid overload. Consider only for the moderate volume resuscitation, that is 1 to 2 liters only, and give these fluids over several hours. So if you do this, yes, you have done a very great job. Then after this, stop giving fluid. If it is a sepsis, if this amount of fluid should increase his blood pressure, should assess his, should increase his tissue hypoperfusion. If this is not occurring, then you need to straight away go for the next line of management, that is the vasopressor therapy in the patient of sepsis. This is not a hypovolemic shock. You just go on putting the patient more and more fluids. If you have a hypovolemic shock, if the patient has a trauma, if he has bled so much, the patient is in shock, yes, give IV fluids, give too much IV fluids. If he is requiring, consider blood product transfusion. So you can consider those kind in hypovolemic anemia. In cardiogenic shock, you know that fluids are definitely not going to help. Just straight away assess the cardiac dysfunction. If they have got an acute coronary syndrome, send the patient for thrombolysis or the coronary intervention. In obstructive shock, you know, if it is a pulmonary embolism, you are thrombolizing the patient. If it is cardiac tamponade, you are considering for a pericardiocentesis for emergency. But what happens in a septic shock is, yes, there is a fluid deficit, but this fluid deficit is not too much. And if this fluid deficit, even if it is too much, the more and more fluid transfusion or fluid resuscitation may not going to help you in any way. As I told you, there is a capillary leakage and there is a venodilatation. So you are giving the fluids on the venous side. So this venous side IV fluid has to go to the heart. The heart is already having some amount of depression, which is not able to pump too much in the background of sepsis. Again, there is a capillary leak. Even if it is able to pump, there is a leakage in the capillary. So what happens in a patient of sepsis? I tell you, if you especially manage these patients based on the CVP, if the patient, you diagnosed him as a septic shock, you take the patient for ICU, you insert the CVP, you measure his CVP is 4. So you're targeting CVP is 8 to 12. So you think that patient is in dehydration, you give a bolus, you give 500 ml of bolus, then it shoots to 8. Then you will consider this, yes, I have resuscitated this patient, he's quite right now. Then you leave the ICU, you just go providing the order to the sister. After 1 hour, the CVP again drops to 4. Because as I told you, there is a capillary leakage, there is a myocardial dysfunction occurring in this patient. So this, again, whatever the amount of fluid has been given to the patient, again leaks in the capillary bed, ultimately causing the fluid overload in the patient of sepsis. So you should not drown your patient in this too much of salty fluids. This is very, very important. So if it is absolutely dehydrated, yes, you can consider giving up to 2 to 4 liters. If it is patient is fluid overload, don't worry about IV fluids, go for next step of therapy. If you cannot directly assess if there are no absolute signs of either fluid overload or dehydration, consider moderate volume resuscitation. Don't be too aggressive and be continuously managing the patient. Sit in ICU, go on managing the patient every hourly, go on seeing the patient every hourly, look whether the urine output is increasing or not, look whether the patient's crepitations are appearing or not, if the patient is improving or not. These you should assess in a dynamic way. Then what type of fluid you should give? Again, as I told you in the last class, the crystalloids are the preferred kinds of therapy in all these emergency fields. And the among the crystalloids, the dilemma is from the balanced crystalloids to the isotonic saline. The balanced crystalloids are very importantly, one is our ringer lactate, another one is plasma light. Normal saline is again a crystalloid, but as I told you, there is a very high risk of hyperchloremic metabolic acidosis, which can be very dangerous in a patient of pre-existing kidney failure or in a patient of sepsis again. So don't consider isotonic saline when you are giving more than 2 liter or 1.5 liter. If you are decided to give 1.5 to 2 liters, provide RL, it is much better solution than the isotonic saline. Yes, if you are giving 500 ml, if you are giving 1 liter, you can consider giving hypertonic saline. Although there is definitely crystalloids are better than colloid, but among balanced crystalloids and isotonic saline, a lot of studies have been undertaken already, but none of them has to be proven superior to the other things. You can either go for NS or ringer lactate. Again, as I'm repeatedly telling you that guidelines are not everything. You need to go through your individualized way of practice. So prefer ringer lactate when you are giving too much fluids, and prefer isotonic saline when you are giving less fluids. And you can consider that 5% albumin when the fluid requirement is too much. So this is a very controversial statement. The fluid requirement is actually not too much, and if it is actually requiring too much, your fluid is leaking in the capillaries. So this is what is very, very important here. Then you can consider the patient directly for vasopressor therapy. Meanwhile, while doing this, you should take the blood culture. This is a very important thing when you're managing the patient of sepsis. You need to take two separate sets of blood cultures, one for aerobic, another one for anaerobic, and ideally it should be taken within 45 minutes. So this, I have mentioned this particular slide because this can be the entrance question. The time given to take the blood culture is within 45 minutes of the patient. And this another remaining 15 minutes, you should give an antibiotic shot after taking the blood culture. Even if you take the blood culture after giving antibiotic, irrespective of any antibiotic, the chance of growth reduces by 30 to 40%. Please remember it. Even if you give a simple ceftriaxone in a patient of sepsis, if you take the blood culture after giving the IV antibiotic, the chances reduces by very high amount. So this is very, very important. So IV fluids, the cultures, and the empirical antibiotic therapy, a very, very important thing. Don't delay the administration of the proper antibiotics, because this delay is associated with a significant increase in the mortality. And this appropriate antibiotic should be administered within 1 hour of recognizing sepsis. That is what is called 1 hour bundle. So this is a 1 hour bundle of sepsis. So what this mentions is, when you recognize that patient is in sepsis, within 1 hour, you need to do few things at a similar rate, like not one after one. One person should take a blood culture. One person should give antibiotics, administer fluids at 30 ml per kg, send blood for lactate. This is what is the sepsis 1 hour bundle. Within this 1 hour, you need to do all these things. Earlier guidelines in 2016, when I was doing post-graduation, it was 3 hours. In recent 2021, this was reduced to 1 hour. So have you ever taken a blood culture of a patient within 1 hour of admitting the patient? This has been impossible in India. This has been impossible in any part of the world. So that's why the sepsis bundle, there's a lot of criticization. What happens in USA is, for example, if the patient has improved from the sepsis or any septic shock, then you are waiting for his insurance reimbursement. What the insurance guy will check is whether you have taken this blood culture within 1 hour or not. If you have not measured the lactate, if you have not taken the blood culture within 1 hour, if you have not administered the 1 hour antibiotic within 1 hour, then his insurance will not get clear. That's why a lot of issues are being coming regarding these guidelines. Although in India it doesn't matter, but you should know this as early as possible. You will not define the term, but as early as possible. Unnecessarily, don't delay the administration of antibiotics. Again, I want to specify here, when I was in first year post-graduation, there was one of my particular unit head was very, very much concerned about the antibiotics. So he used to make sure that the antibiotics are to be administered on his rounds only. If at all he changes the antibiotics, it is to be administered in front of him only. Then we used to see why the consultant is doing this. Anyway, this can be done after the consultant is gone. After reading the importance of sepsis and the deaths due to sepsis, the importance has been understood that the administration of an antibiotic as early as possible reduces mortality by very significant amount. So a right antibiotic at a very right point of time, as soon as possible, is a thing in sepsis. Okay, but which antibiotic? Again, a lot of guidelines mentions the antibiotics depending on their considerations, but ideally it should be a broad spectrum. It should not be a narrow spectrum. For example, a vancomycin. Vancomycin is a very narrow spectrum antibiotic. So it is usually given for a coverage of a single organism, that is an MRSA. It is methicillin-resistant Staphylococcus aureus. So many of the hospitals in Western population do include vancomycin in their regimen of sepsis, but in India, MRSA is not a very common until and unless we are suspecting some amount of the soft tissue infection, etc. You should usually go for a broad spectrum antibiotics where it covers all likely pathogens. And you should consider the multi-drug resistant regimens. That is combination of an antibiotics with a different mechanism of action. Rather than a single antibiotic, go with the two antibiotics with a comprehensive mechanism of action, which can cover the multi-drug resistant organisms also. Then consider the site of infection. For example, the urinary tract infection may warrant meropenem. The pneumonia may warrant the Tazobactam. So like this, you should know the site of infection. The previous antibiotic use is a very, very important thing, especially when the patient is shifted from one hospital to another. The local susceptibility patterns, you should know. The area in which you are working may have a typical resistance existing in the bacteria, and the pre-existing immunosuppression and the risk for the resistant organisms like the MRSA, the Pseudomonas, the Enterococcus faecium. Then you might have heard many organisms called Acinetobacter. Then there is something called a Stenotrophomonas maltophilia, dangerous organisms. And nowadays the E. coli. So the resistant organism, you should know the details, what are the chances of patient having resistant organism. So, and dosing is very, very important. The clinician should pay attention to the maximizing the dose in patient with sepsis. Use a full high-end loading dose where possible. For example, if the dose mentioned that 50 to 100 mg per kg, I'm just giving an example. So go for 100 mg per kg. Don't go for 50 mg per kg. This is what this means, especially the loading dose. The first dose of antibiotic should be the maximum dose, a very high end of this range. And this strategy is because we know that it is a vasodilated state. So the volume of distribution of the drug gets increased in the patient of sepsis. That's why you need to administer much higher dose compared to an uncomplicated infection. I have seen patients, this has been, I think, multiple times I'm mentioning the dose of Pibzo. Many of the people give 4.5 gram BD, a very, very wrong dose of Pibzo. It is always given 6th hourly. And for example, if the patient has raised creatinine with a low creatinine clearance, now you need to modify the dose. Whereas loading dose need not be modified. The full dose of loading dose should be given. So you should give a 4.5 gram of Tazobactam, then followed by the 2.25 gram every 6 hourly, depending on the creatinine clearance. So this is a very, very important. The dose should also be given a concern. So these are the suspected bacteria in the depending on the site. You might already know this. So this is again an example. I don't want to go in detail for these examples. The pneumonia I have already mentioned in my pneumonia class. For the biliary tract infection, it is usually the gram-negative bacteria. So go for a combination of ampicillin, sulbactam, or preferably meropenem. So this is very, very important. If the patient has, for example, an ascending cholangitis, and you are giving the patient the vancomycin, then it is of no use. So this is what is the right antibiotic means. You should cover the most probable organisms. Tazobactam. Although if you are suspecting the gram-negative infection, the meropenem holds a higher rank here. And with diabetes in the background, you should usually cover the anaerobes also. Routinely, we don't cover the anaerobes. In the intra-abdominal and pelvic infections, again, it is a gram-negative. The meropenem, Tazobactam with the tigecycline coming into the picture. And you can involve the clindamycin or metronidazole also to include the possible anaerobes. The bloodstream infection, very important is, it is a very important risk factor for the invasive fungal infection, especially the candida. So you need to consider this fluconazole or amphotericin B. So urosepsis, Again, you can consider for the fluoroquinolones, these 4th generation cephalosporin. Again, the meropenem holds good along with the piperacillin tazobactam here. So, as I mentioned you, this is the 1 hour sepsis bundle. So what should do? You should measure the lactate, obtain the blood culture, then administer the broad spectrum antibiotics, begin the fluid administration at 30 ml per kg, then apply the vasopressor if the patient after giving fluid does not improve with the mean arterial pressure. So what is time 0 here? Time 0 is the time of presentation, time of triage in the emergency department or presenting from another care venue. This is very, very important. So you are given fluids and you are given antibiotics. What will you do? Now you will monitor the patients for the response. So you will monitor the catheters. You might have inserted your central line. You might have inserted the urinary catheter. You might have inserted the arterial line. You should monitor these catheters. Clinical monitoring should be done. Labs should be done, and the hemodynamic monitoring should be done. So for the central line, you will measure the CVP. If you have got an arterial cath, check the patency of the arterial cath before mentioning the intra-arterial blood pressure. So this is very high tendency to get blocked in the arterial cath. So any time taking the, especially when the sister has written the readings in the ICU, the arterial catheter is actually blocked. There is a tendency that sister might have entered the wrong values. So SCV2 is a central venous oxygen saturation, which has been obtained from the central line. Again, the earlier time, the CVC and SCO2 used to be called as the hemodynamic parameters, but these are not used nowadays routinely. And clinically, keep on calculating the mean arterial pressure and the urine output. The urine output is very, very important. The urine output should normally be at least 0.5 ml, half an ml per kg per hour. For example, if the patient weighs 60 kg, he should at least pass 30 ml of urine per hour. This is what the meaning is. So in ICU, the system mentions the every hourly reading of urine output. So this drop in urine output appears much earlier than the drop in the blood pressure, if the entered report is very, very right. So if your sister is very good in managing the urine output, or if you yourself are managing the urine output as a duty doctor, then none of the signs carries much significance than the urine output. Please remember this. So be careful monitoring the urine output very frequently and very comprehensively. Then hemodynamic assessment. We know that there are static measurements. I have mentioned in the last class. The CVP you're targeting as 8 to 12, SCO2 you're targeting 70. Earlier, we used to manage by targeting this CVP and the SCO2. The terminology given to that kind of management was early goal-directed therapy in the sepsis. You give fluids, you wait for the CVP to 8, to reach 8 and SCO2 reach above 70. So go on giving fluids till the CVP reaches 8. Sometimes even after giving 12 to 15 liter in the 24 hours, the patient never used to achieve the CVP, ultimately used to die with the fluid overload. That's why the early goal-directed therapy has been removed and the static measurements have been under question whenever there is a huge hemodynamic measurement is required in the patient. Now there are dynamic assessments like IVC diameter, the pulse pressure variation, the aortic blood flow pressure variations, and the pressure variations along the arterial flow. So you can measure all this hemodynamic measurements, but these are all for theoretical purpose. None of the ICU measures this, including the intensivist. In laboratory, very important is lactate. And again, you are assessing for some inflammatory markers like CRP, the calcitonin, and the ABG, and the routine lab investigation to assess the end organ dysfunction. So after diagnosing the patient of sepsis and the initial resuscitation, that is, fluids have been given, antibiotics have been given, but yet his MAP remains below 65 and his lactate is above 2 millimoles. Then the patient is called to be in septic shock. Now his mortality chance is 40%. Earlier it was 10%, now it is 60%, 40%. So what happens in this septic shock? As I told you, there is a venodilatation, there is a capillary leak, and there is a myocardial dysfunction. So ultimately causing tissue hypoperfusion. In this tissue hypoperfusion, the cells shifts from aerobic to anaerobic respiration, and this anaerobic respiration ultimately produces lactate instead of producing ATP. So this increases the lactate concentration in the vascular bed. This is the basic reason for the lactate hyperlactatemia occurring in sepsis. So this increased lactate is a marker of tissue hypoperfusion or the level of sepsis. But there are two concepts in the septic shock. This is beyond scope of this particular discussion. You can ultimately go and read about this value of lactate in assessing the septic shock. So when you follow these formal definitions, they are more relevant to the clinical trials than bedside management. So this is very, very important, because whatever the definitions, the management, the guidelines mention, they are for the epidemiological purposes. They are not for the bedside management of individual patients. So they are blunt tools. The guidelines are the blunt tools. They are highly inadequate to direct the patient management. Instead, the diagnosis of septic shock should be made carefully on an individual basis. This is what I want to tell you. So to assess an individual basis, the doctor has to be trained well in assessing the hemodynamic status of the patient. So if you happen to diagnose a patient on septic shock, so try to increase his mean arterial pressure above 65 promptly with the peripheral vasopressor infusion. So traditionally, the guidelines tells that first give adequate fluids before starting inotropes. This is what the guidelines tell, but the correlational evidence tells you that the longer the duration of hypertension increases the risk of renal failure and ultimately death. So you have waited the patient to give fluids, then you are thought to give more fluids, you might have gone into lunch, then you met somebody in the lunch, you took 2 hours before coming to the hospital, the 6 hours has already gone before starting the antibiotics, the inotropes. Here the risk of having the patient renal failure increases and ultimately leading to death. So what usually I do in the case of septic shock is, I start the patient on peripheral vasopressor along with the IV fluids. So with one cannula, I start the patient on the IV fluids. If the patient has another cannula, directly straight away start with the patient on the peripheral vasopressor low dose. So if the patient improves following the fluid resuscitation, then you can wean off the vasopressor. If there is no improvement, then the vasopressor requirement is escalated. Then you can take the patient transition to the central line, adding the another vasopressors. So which vasopressor is the choice in case of sepsis? The guidelines tell you that the first choice should be the norepinephrine. So we are using the vasopressors. As I told you, in the sepsis, there is vasoplegia. The vascular tone is being paralyzed. There is a huge vasodilatation. So you need to address this by compressing the vessels. So you want the vasoconstrictors. What happens if you start the inotropes here, the dobutamine, the milrinone? So they are cardiac inotropes. They increases the inotropy and chronotropy of the heart. This is not the problem here. They have been indicated in the cardiogenic shock. Here it is a distributive kind of shock. There is a huge vasodilatation. So you want to constrict these vessels. So the first choice of vasopressor is the norepinephrine here, which is a potent vasoconstrictor. Then the vasopressin and the adrenaline. This is what the guidelines mentions. So how they usually act, you should know. The norepinephrine increases the systemic vascular resistance by vasoconstriction. I'm not going away with the effects of the alpha 1, alpha 2, beta 1, beta 2, etc. Here I will take this when I discuss the approach to shock. To be brief here, and you might have already know this in case of your pharmacology lectures. Norepinephrine is a potent vasoconstrictor due to its mechanism on alpha 1 is very high. The action on beta 1 and beta 2 is very low. That's why it causes a vasoconstriction, increasing the systemic vascular resistance, increasing the BP. What does the epinephrine does? Epinephrine does the same, but along with the increasing the systemic vascular resistance, it also have a positive inotropic effect. Especially the low dose have got a beta predominance action compared to the alpha, so it increases the cardiac output also. What does the vasopressin does? The vasopressin actually increases the systemic vascular resistance because it is a pure vasoconstrictor by its mechanism of action on V1 receptor. So if you increase the dose, it can also cause the coronary vasoconstriction. This coronary ischemia can occur, the mesenteric ischemia can occur. That's why it is not the first choice of vasopressor in case of septic shock. Only if the patient is not being maintained on noradrenaline, then the patient has to be shifted on vasopressin. That's why it can reduce the cardiac output by causing the coronary ischemia. You should know this. So the possible choice of an initial pressure should be an alpha agonist should be considered as first because we want a vasoconstriction in our patient. So phenylephrine is a potent vasoconstrictor, but it increases the heart rate. The phenylephrine is not a very good drug, especially it can cause arrhythmia. So it usually considered as an alternative to norepinephrine if the patient cannot have a central line. This can be given on a pure peripheral line only. Whereas norepinephrine is better if you give to the central line only. So, which is a well-suited vasopressor for the septic shock is the norepinephrine. If the beta agonist epinephrine, along with the constricting the alpha-1 receptors, also has got a beta action, so it is a second choice of an antibiotic. It can be considered when there is a background bradycardia. So nowadays, there has been a tendency to use a combination of vasopressin plus epinephrine because a vasopressin is an excellent vasoconstrictor and an epinephrine is a powerful and excellent inotropic. So nowadays they are using a combination to the sickest patient. So in the one line, you are providing the norepinephrine, and another line, you are providing the combination of vasopressin and epinephrine. And they have given the terminology for this called vepinephrine. This may not be required for the undergraduates, but this can be the question for the postgraduates and NEET SS. Now, what is the role of steroid in the septic shock? Usually, we don't consider the steroids routinely. They are not recommended routinely. Very important. And you will consider the septic shock. Whether is there any probable adrenal insufficiency if the patients can have Addison's disease, if the patients has chronic steroid use, then you can consider for steroid. How will you assess this Addison's disease? I will give you a very, very simple thing here. Calculate something called as NLR, which is a neutrophil lymphocyte ratio. So in any infection, there is a stimulation of an innate immunity in which they stimulate the neutrophils and they stimulate an adaptive immunity which stimulates the lymphocyte. So what happens in sepsis is, sepsis, initially there is an increase in the neutrophils by preventing their apoptosis and increasing the production, and due to a stressful condition, they produce a steroid which reduces the lymphocyte count. So by increasing the neutrophil and reducing the lymphocytes in case of sepsis, the ratio increases. The neutrophil lymphocyte ratio increases. So more the neutrophil lymphocyte ratio, more the sick the patient is. This is how you can decide depending on the NLR. And this NLR can even increase much before the appearance of the leukocytosis, high CRP, high procalcitonin, etc. So NLR can be very early in your patient. So this can be a useful tool in managing any sick patient indeed. Whenever you see a CBC of a patient, you see that neutrophils are high, lymphocytes are low, then condition is very important. Whatever it is the condition, be it acute pancreatitis, be it a sepsis, be it a stroke, be it an acute myocardial infarction, you need to admit this patient and monitor this patient, very important. And if the patient is having a proven sepsis and his NLR is low, this can be a feature of an Addison's disease or an adrenal insufficiency in the background of sepsis. So then you can consider the hydrocortisone in this patient. And you should know if there is contraindications exist for the steroid, patient is having a brittle diabetes, if the patient is having delirium, there is an invasive fungal infection, the patient has severe neutropenia, so you should never give the steroid in this patient. And you have already given the vasopressor dose and the patient is in refractory shock, then you can try a dose of steroid in the patient. So how will you give a steroid? We will give a stress dose of steroid. We will give 50 to 100 mg IV every 6 to 8 hourly. This is how we give steroid in a case patient of refractory shock, but they are not recommended routinely. In future guidelines, they may include routinely like COVID. So as of now, we are not giving steroids in the emergency. This is what every intensivist tells, but if you ask them personally, every intensivist is giving steroid to the sepsis whenever the patient does not respond to the vasopressor. So as far as answering in the exam is concerned, we're not giving steroid, but you can consider stress dose provided patient does not have any fungal infection, patient does not have any brittle diabetes, patient does not have any delirium, patient does not have any severe neutropenia. You can try a dose of steroid, but only after the adequate fluid therapy and the vasopressor therapy. So the highlight is don't follow the guidelines blindly. You should know these signs of hypoperfusion. How will you assess? So be it any patient, you should know these signs. The SPP is less than 100, the MAP is less than 65, the heart rate is 110, the shock index, which is the ratio of heart rate to the systolic blood pressure, is more than 1, the elevated serum lactate, the capillary refill time is more than 3 seconds, the decreased mental status, decreased urine output. So if many of the patients are fitting into these criteria, yes, there is a tissue hypoperfusion occurring in this patient. Then how will you assess the patient is having fluid overload or not? The patient, after giving fluids, developing crackles in the lung. So these can be the signs of fluid accumulation or an ARDS in the patient. Or your JVP is distending with the fluid administration. That means the patient is having fluid overload. Or if the patient is ventilated in the mechanical ventilation, his work of breathing is increasing after giving IV fluids. Or if the patient is on oxygen, he's going into hypoxemia with more and more fluids. So these are the features that tells you that patient is going into fluid overload. Then obviously you can get a chest X-ray, which has got a very low sensitivity in detecting pulmonary edema. If you have got a bedside availability, a very, very easy sign to see is the appearance of B lines, which can be consistent with the appearance of pulmonary edema. So you should know how to differentiate between the fluid overload and the hypoperfusion. If there is a hypoperfusion, give fluids. If you don't know, give fluids and see for the appearance of this fluid overload signs. So thank you. Again, these lecture this I took is not to entirely cover the topic, but to make you habit of not blindly following the guidelines, especially the sepsis guidelines. We have a thorough knowledge. Go on seeing the more and more patients in your routine life. If you are postgraduate, sit in ICU, even though it's not your duty. See what the consultant is ordering. See what your senior postgraduates are doing, how they are doing. So this is very, very important. If you're an undergraduate, definitely there is a lot of time to learn and try to learn good things by the good physicians.